Dr. Jeffery Gross, welcome to the Pain and Performance Podcast.
Thank you so much. Great to be here. I appreciate it.
I feel like we're going to get a lot of both of like the ethos of the Pain and Performance Podcast in this, like the pain part. What do we do to fix some of that stuff? How can we use like regenerative medicine to boost performance and maybe start kind of thinking about some longevity stuff? Before we started talking, one of the things I think is a big misconception among everyone, practitioners, doctors, patients, is that like regenerative medicine is stem cells. And like that's where they start. And they're like, oh, you mean stem cells? And you're like, well, there's a lot under that umbrella. Um, let's kind of get the groundwork laid so that people kind of have a decent understanding of what we're talking about. So you've said before there's a few different flavors, and I love the way you say that, of regenerative medicine. Can you explain what those flavors are and what they mean?
Yeah, happy to. Thank you. So this is a little regenerative medicine 101, so we can really get a lot out of the conversation today. I appreciate that opportunity. But, just basic biology is when we are created as an embryo and then a fetus and a baby and then we grow, um, there are cells that are dividing, and those cells are called stem cells. And that is the buzz phrase. So when we talk about regenerative medicine, we're talking about stem cell medicine. And that means it's based on stem cells. But stem cells aren't the only method or vehicle, or what we like to say, the only biologic that can help. And I like to put the regeneratives that are typically available into three buckets. Now, there are more that are coming experimentally. We talk about reversing cells back up the pathway so they can divide into anything. These are called induced pluripotent cells. Don't worry about all these fancy words, but the stem cells that we talk about when we go into these three categories are typically they've divided out, and all they can do is divide into tissues in our body. And these are typically called mesenchymal stem cells, or MSCs. And this is what's in our adult bodies too. When we're an embryo, those stem cells have even more availability and power to divide into different things. So we're really focused on these sort of end user stem cells. They help keep us going and help us heal and regenerate during most of our adulthood. Okay. So a lot of the three categories come from history. One of the very first applications in regenerative medicine is called PRP. And that's, most people have heard of PRP, but just for those that might not have, it stands for platelet-rich plasma. And what that is it's taking your own blood out of you, or at a doctor's office or something like that, usually a number of vials. It's put in a little tabletop centrifuge. It spins the tubes, and because of the centrifugal forces, separates out the red blood cells, which we always associate with the color of blood, and the different white blood cells and plasma and different other sort of the watery constituents of blood. And in between that red and white separation, there's a little area of these cells called platelets, which is also made like blood in our bone marrow. We'll come back to that at least once, I'm sure. And those platelets are rich in growth factors and help with healing and fighting inflammation. And if you suck those out of all the tubes and add them together, you can inject them back like into a tendonitis of the elbow, like a tennis elbow or an injury in the ankle or something like that. And typically over a few applications, maybe 2 or 3 times, you can accelerate your own healing. Because as we age, we just don't heal as efficiently or effectively. I mean, think about it, Derrick. You take like a 3-year-old, I don't know if you have young ones, but you take a little one, a little boy is running on the sidewalk and he scrapes his knee and he's got an abrasion there and he's crying. His mother cleans it up, puts a Band-Aid on it, kisses him, sends him on his way. And a couple days later, the Band-Aid falls off because he's a kid and it's not going to stay on long. And would you know that scab is almost completely healed? When you look at an adult, like me, I'm pushing 60. Man, I scrape my arm. I don't heal that fast. So it's kind of crazy how fast kids heal. Why? Because they have all this regenerative activity. So platelet-rich plasma is one of the ways to get tap back into our own body's ability to heal. Then the next level up from that, level 2 of 3, is actual stem cells. And this is the buzzword, right? And these can come from your own body. They usually take them from the bone marrow because that's the richest source. And you think about it for a minute, bone marrow is a highly rich thing you find on a menu. It's nutrient dense. It's got all kinds of good stuff. It's why
the bone marrow.
Right? It's why our grandmother made us chicken soup when we were sick, because it's made from that chicken stock and the bones. It's rich in all these regenerative particles. And so anyway, and you think about it, someone with low bone density, meaning low bone marrow, is probably accelerating their own end of life. Not on their own. It's not their own fault. So as a consumer note, take care of your bone marrow and your muscles, and you'll take care of your longevity, right? Okay. And of course, you're using your muscles, your weight-bearing exercise, you're stimulating your bone marrow. So it all goes together. Right. So you could take these stem cells out of you, but I don't know about you, but when I change the oil in my car, I don't put the old oil back in. Because you can take the stem cells out, concentrate them, that's called BMAC or bone marrow concentrate. And you can put them back in a place where you need them, like the tennis elbow or somewhere else. And most of the research is based on stem cells is based on that, because that's been around for over 20 years. Now, most of the literature and follow-up and clinical uses and studies come from Europe and Asia, not here. It's a bit suppressed here. So we're a little late to the party, but there's been very good work done on this, and we follow that work. And then the third and final level, and then I'll stop hijacking your podcast here. But the third and final level are cell-to-cell signaling particles that we call either nanoparticles or extracellular vesicles, and for cute, we call them exosomes. And what happens is, some scientists were following stem cell delivery from a person to himself or herself, and those cells only last 10 to 14 days, but the benefits lasted much longer. So the reason for that turns out to be that those cells are giving off smaller particles, signaling particles to your own cells to wake them up and activate them and reprogram them, at least temporarily, to heal and regenerate and act more youthful. And these are called exosomes, and these are readily available now too. But I did, forgive me, I skipped. I said bone marrow can come from yourself. It can also come from someone else, and that's called the perinatal source. And this is very ethical. Some people like to insert some controversy here, but this is from a woman who delivers her baby by C-section. No problem with the baby, no problem with the mother. And instead of throwing away the placenta, the umbilical cord, the amniotic fluid, it is now saved and sent to these clean labs and processed, tested, screened, and now made available. And that's the most efficient way to do it.
This is purely out of my curiosity, is that slightly different than like placental matrix whenever they're using that for regenerative therapy, or is it identical, just using different terms?
Placental matrix comes from the same perinatal tissues, the same source, after birth tissues, but it's probably what they take from that and how they process it. And there are many others too. I was trying to generally categorize. So you've got the different amniotic tissues, extracellular matrix. We can go on and on, but basically you have cellular biologics, and then I'll call them cell signaling biologics, which have certain advantages over the cellular. They last longer. They're smaller. You can get them more concentrated. They travel further in the body. They will cross the blood-brain barrier, get into the nervous system, which cells struggle to do. They're too big. And they're less costly. Cells are very expensive right now, but you can get the cell signaling particles at probably half of the cost of the cells.
Interesting. And I know people are listening to this and you're like, okay, we've got this hierarchy. We talk about like even underneath like PRP for kind of minor issues, we'll do like activated peptide therapies where we're
Yeah.
doing some sort of healing stimulant, needling or something to that effect while someone's using a peptide. And it'll regenerate to a degree, right? And peptide or PRP will regenerate to a degree, and then
Yes.
stem cells, and then exosomes. How do people think about like? And I'm sure some of this is a conversation with your doctor, but how do they think about what to use when?
Right. So it just depends on the individual. Everything would be precise for that person, what their goals are, how bad the situation is going into it, what their appetite is. Sometimes we start with something simple and we see where we get the benefit and work our way up to the more complex applications. But I do agree with you. And when we talk stem cell medicine, regenerative medicine, it's best in an optimized person. So someone who is doing the right stuff with exercise and sleep and breathing and nutrition and diet and protein intake and supplements and peptides, and it's the whole package. Because when we do deliver these biologics, I want them in the best environment to take advantage of them, the optimized person.
Yeah, we have to dive into that because we've talked so much about how important taking care of your kind of, functional pillars of health. And if you don't do that, nothing you add on top is gonna really get you there, because even this amazing level of regenerative medicine is still in a lot of ways stimulating your body to do the work, right?
Totally. Yes.
So if your body doesn't have the energy or the capability to do that work because, let's face it, you haven't kept it healthy enough to do it, then we're doing some of these really amazing things and we're putting like this awesome, Lamborghini in like this cesspool neighborhood and expecting it to go and like, transform. And it's just not going to work quite well. So before we get to that, I'm going to come back to that in a minute. So in terms of like something that's more severe, let's kind of get specific with something like this, because I'll see patients with hips and knees and backs who are like, I don't want to have surgery. And we're always trying to identify, okay, what is the underlying cause of the tissue dysfunction? Why is that knee tissue unhealthy? Do you have a movement related problem? Do we have an imbalance that's causing you to really move that joint in some wacky ways that really degenerates and wears out that tissue or the spine? So in those people, if they're starting to look at going through this, would you say, hey, look, okay, you start with the movement, then do kind of, not necessarily the least costly, but maybe the least invasive first, and then continue to climb that ladder, at least, in most situations?
Yeah, generally speaking, again, depending on how bad things are, we have this is my low-hanging fruit because we get so much benefit from the regeneratives for joint problems. And like you said, these are degenerating joints. And if you think about it from a degeneration and regeneration are sort of opposites. So the body has been trying to maintain this joint for so long, and eventually the degenerative cascade wins out over the ability to self-heal, to regenerate it. And there's an inflammatory component. So we start with inflammatory lifestyle, inflammatory diet, which I know you've talked about in the past, all kinds of things. And then we go into, we're getting away from cortisone shots, right? I mean, cortisone has its role. And when I use the word cortisone, it could be any anti-inflammatory steroid, but we commonly refer to those as cortisone. But repeated cortisone shots in a joint are actually detrimental to the joint in the long run. It suppresses the regenerative cascade. So although in severe pain situations, it might be the right thing, we're trying to get away from that. And we're trying to really get away, like you said, from patients getting so bad where all the things they try lead them to a doctor who says you're bone on bone or you have arthritis. And these are just general terms for a degenerated joint specifically, unless you have a disease of arthritis, which is different. That's rheumatoid arthritis. So those patients are usually offered joint replacement. We're trying to insert ourselves before they ever get to that point, and hopefully never get to that point. That's the real goal. So that's where the regeneratives come in. And you're right. We start with, all the various therapies and, building the muscles around the joint and the anti-inflammatory activities. And then if those are ineffective, we can go, whether it's PRP or depending what the MRI looks like, we might go right to exosomes.
So if you look at the MRI and you're like, look, there's not a whole lot of viable cartilage that looks healthy in there, you're going to kind of, hey, look, let's not waste time. Let's go right to the kind of powerhouse of this stuff.
Right. I mean, and that's what we call bone on an X-ray, even though it's not actual bone on bone, because there's usually something there. And I gotta insert this, if you allow, that think about it. When we were creating our own bodies as a fetus, our bone marrow at the far end of our leg bone, the femur, and the upper end of our lower leg bone, the tibia, created that knee. They made that cartilage. So we're tapping back into the stem cells in the bone marrow just above and below that joint to ask it, hey, can you make another part? It's like going to the factory and getting the original equipment manufacturer to remake the knee. That's what we're doing.
And I think that's when people hear of like regenerative medicine, that's what we're hoping for, is like, and I get the question all the time, like, if I do this, am I going to have a new shoulder? And that's what our brain goes to. And you're like, I mean, I hope so. That's what we're trying to do with this research and with this medicine, is get it to the point where it made new tissue there. It made a whole new knee, like you did when you were developing.
Right, because we take away the inflammation causing issues, the chronic years of overstressing that joint, micro injuries, maybe real injuries. Then we can let the body focus on its own regenerative capacity. But the body needs help, right? Our own stem cells have been exposed to the same things our cells have been exposed to for decades. So if you're like me and you're 57, you've had 57 years of questionable food when you were growing up. What's in our water? I'm not sure. What do they put on the plants when they harvest them? I don't know. Electromagnetic waves, all kinds of things in our environment that cause our cells not to function as well. Accumulate our own cellular inflammation. That's really, if we can get rid of that, and we're fighting against it. That's what we're doing.
You said at one point, if we can reduce the need for big surgeries, we're onto something great in regenerative medicine. How many surgeries do you think we're doing right now that if somebody went the regenerative medicine route, they would have a better outcome with less pain, in the long run?
Well, I don't want to find myself buried in the desert, because there are a lot of companies that make billions of dollars that make implants, which is why I got into this in the first place, trying to get away from that, right? But I would love to say it's over half of them at this juncture. And to be clear, there's always going to be a role for surgery. There are people with problems that are structurally unsound or need to be really reconstructed in a different way. And maybe we combine those with regeneratives and we don't have to do as large a surgery. And we can use fewer mechanical parts. We can go back to the original biologics, which are optimal. They were designed right. So I would say it's going to be a staggering percentage.
I mean, I would agree with that. What we see in our practice is it seems to be like that it's somewhere in that 50%. Was there a time before you, was there a really frustrating case that led you down this? I'm interested that, how did you start to make the decision that, look, I've been going on this path. I'm gonna take a right turn.
Yeah, I had a path where, as traditionally I'm a neurosurgeon, spine fellowship trained. My entire career, I'm on my 25th year now, so my entire career was, trying to help people, not have surgery, and then if I failed at that, then doing the best surgery for them. Maybe it wasn't a good, I'm not a good businessman per se because surgery is a big ticket item, but it was my patients who came to me frustrated because at the front end of spine care, and this applies to other joints too, you have injections and you have therapies and you have time and anti-inflammatories. And, a lot of people get that in the early going. And then on the far end, you have surgery. And spine surgery hasn't changed drastically in 50 or 60 years. We're either decompressing, making more room for nerves, or decompressing and fusing, which is locking things together, which is pretty barbaric still, even though we need it in some situations. So those are like two categories, haven't changed drastically in decades. And the people that trained us to do that were trained by people that were trained to do only that. So it hasn't really changed, even though there's a new bell or whistle here and there. It's really the same. So patients would come to me and say, Doc, these injections, therapies, they really didn't do enough. I still have back pain, but I'm not, I can still work and I can still live, and I'm not ready to have screws and rods put in my back. And the number of patients in that category were growing, and they'd come in and ask, is there anything else? Oh, we could try more therapies. We can keep doing this and that. And they would ask because they heard the phrase, how about stem cells, Doc? Eventually I listened to them enough and I went and got retrained. And so I could help add a tool to what we offer people that fills that gap.
Love it. Love it. That's to me, if you look at what the future of some of this stuff, I think you hit the nail on the head where it's like, can we use some of these biologics in conjunction with some of the stuff that we're doing, so that we're not only healing the tissue that's damaged, but maybe correcting the reason it was damaged in the first place. Did they have some sort of underlying issues or movement problems or asymmetries or some lifestyle factors that led to the tissue to degenerate? That's where this gets exciting, because now you're improving the tissue health, but you're improving the reason the tissue was unhealthy at the same time.
Agreed. We're being able to do these new things has helped me understand how the joint and how the spine degenerates better, and renews our ability to come up with new ideas on how to apply all these different things strategically for an individual.
So you were talking about stem cells for joints, and at one point I heard you kind of do a really good explanation of Dr. Hernigau's study on knee arthritis and how maybe we should be applying that to other areas. Let's double click on that for a minute.
Excellent. Appreciate that, because I really follow his protocols. And this is, for those that don't know, he's a French orthopedic surgeon. And 2 years ago, he published his 17-year follow-up in one of his knee studies. So they've been doing, 15-year follow-up. So that was 2 years ago. So now it's 17 years. So he's got at least a 17-year experience. And he's the one who clearly defined, without question, that the party is in the bone marrow. It's not in the joint. So if you look at a lot of American studies of spine and joint regenerative medicine, stem cell medicine, they're injecting the joint in the soft part of the joint, the meniscus of the knee, the disc of the spine. Hernigau clearly studied and demonstrated that you get much better and longer lasting benefit if you inject the bone marrow just adjacent to that soft tissue structure. And you think about it for a minute, our discs of our spine and our meniscus of our knee as examples, that is the sort of biological rubber, the moving part. There are not a lot of cells in that tissue. That is not a very biological tissue. It's sort of a biological rubber. The activity that made that cartilage in the first place is in the bone. And to ask your body to heal it, make more of those proteins, improve that cartilage, you got to take care of the bone. And he clearly demonstrated that, and that's how we apply his work here when I help people. And the party's in the bone marrow. That's where your stem cells are, the most of them are, and that's where we reactivate them and rev them up to help produce the proteins they made in the first place, the cartilage proteins.
What was the difference between the outcomes of those two? Do you remember, like
Yeah.
the people in the joint versus the people where they treated the bone?
Absolutely. I have the screenshot on my desktop. I share it with patients all the time. After 15 years, because it wasn't very different at the 5-year mark, it became more different at the 10-year mark. And at 15, it was clear and convincing that about 20 some percent of the knee uh, patients who were treated in the joint cartilage still were doing well after 15 years, whereas it was in the 80s of percents in the bone injected people were doing well at the 15-year mark. And these patients to start were recommended knee replacements. So they took people who were recommended by an orthopedic surgeon to have a knee replacement. They were degenerated enough. They were either bone on bone or osteoarthritis or whatever words they used at the time. And instead of having that surgery, they said, hey, why don't you join our study? And half those people got the bone injection, half got the joint cartilage injection, and they have been following those people.
Is that something that you would like if people are listening to this and they're like, okay, I'm considering this. What questions do I ask my, physician, my doctor, in, the area that I'm in? What are some of those questions that they would ask that kind of gives them information about how they're going to go about the regenerative procedure?
Well, they should ask their clinician who is recommending whatever treatment, what are all the options, right? And if they don't get a regenerative option, they should seek one. Because again, a lot of orthopedic doctors who treat knees are trained by orthopedic doctors who treated knees in the 1970s and 80s, and it just hasn't changed that much. Yes, there's a new implant, a new kind of artificial knee, maybe it moves differently or is easier to put in or something, but again, we're trying to avoid that. So they need to ask for all the regenerative options, meaning, are there any stem cell options? If they get a flat no, then that just means that doctor was like me a number of years back, where we just haven't been trained to know about it or to advise patients about it. And you got to find someone who is, and they're out there, they're on the internet, and should always get a second opinion before surgery anyway. And we do a lot of that for people remotely. You don't have to come here to Nevada, especially in the summer.
Well, look, my patients are coming from Louisiana. They're like, it's got to be better. Anything that we can go to has got to be better than this. Um, when we're kind of working through some of this stuff, right, and patients are getting stem cells, what's the best stuff after? How do we make sure that we are supporting the development of that process after somebody gets stem cells? So I've had a procedure done on my knee, my hip, my back. What does that next kind of phase look like that really maximizes my outcomes?
Well, we don't recommend downtime. We want people to be working and stimulating the mechanoreceptors. I know that's kind of a crazy word for a lot of people, but the little sensory endings that feel the movement in the joint, and because it stimulates the activity and the recovery of the cellular activity and around the joint. So we want that. So we like people to, if it's a knee, to start walking, start using the knee, a little bit of weight bearing activity. A good therapy program would be great. If they haven't already, you know, if they need more muscle, then we work on, different ways to do that. I know you've talked about blood flow restriction. I'm a big fan of Vasper and that kind of thing. If you can find it, it's not everywhere. And peptides, there are great peptides for muscle growth. And there are, in addition, you got to have protein. You got to have good protein intake. A lot of us who are trying to put on muscle or maintain muscle are just not getting enough.
Especially as we age, right? You look at it and it's like, a young kid might be able to eat 15 grams of protein in a meal and start like muscles growing, but it seems like our requirement, if we're really trying to maintain or develop muscle as we age, it's like, protein becomes like the only thing I tell my patients to track. I'm like, you don't have to write down everything, but let's follow how much protein you're getting.
I agree with you. And I have a lot of the same here where, the regenerative piece has blended over into a whole practice on health and wellness and anti-aging, and because it's the same thing. If we're regenerating, then we're not degenerating. So it's anti-aging. But you're right. I agree with you. I don't think as Americans we get enough protein. I mean, look at Europeans. They wake up and for breakfast they have protein, and we're supposed to have breakfast cereal, and that's it. I don't think so.
This is interesting because I see this as how it happens in my practice a lot, where somebody comes in with a pain problem. And we work on that, right? We fix the movement issues, the tissue issues. If we're catching it early enough and there's not degeneration, if there is, then a lot of times we're working with doctors like yourself to try and, get them completely healthy. But it also serves as this gateway, right? Pain is a very powerful motivator. And so when we start with that patient, it's very common that that gateway leads to, okay, well, here's the next things that you should do to live healthier and better. I mean, look, that's what this podcast is about, right? So it sounds like you've kind of had a similar thing. You start working on this and they're like, well, how do I make sure that I get healthy after this? Have you seen that? Is that where some of the longevity stuff that y'all do kind of came from? Was it just kind of a happy byproduct of working with people after their pain resolved?
I'm not sure that was the origin in my own practice, but I really work with people to get that started before we do anything regenerative. And because people generally fly in for care, I have the opportunity to meet with them by Zoom and sort of get the right milieu or soup going in their bodies first. So supplements, sleep, everything, to get what we can, so that the body is they already have the knowledge and the behaviors to get the most out of a regenerative procedure. The anti-aging group actually came a little bit by accident. I joined because I'm sort of a biohacker, and the biohackers blend over with the anti-agers so nicely, and I just fell in love with the biohacking community, and I said I finally found my people. So.
Love it. When you're talking about like the support stuff after, you said, do you have kind of a top list of like, hey, these peptides work really well, these supplements are things that at least should be on the consideration list if somebody's getting a stem cell procedure? What's that suite look like after?
Yeah. So again, this a lot of this we start before, but
yeah.
I try to have everyone. I try to gauge their appetite for this, right? If you're not a guy who wants to take a lot of pills, I've got you on. I'll call it the starter anti-inflammatory pack. You're on fish oil 3 times a day, probiotics. You're doing melatonin at night, whether you sleep well or not, and you're doing. So we do magnesium at night, and let's see, what's my 5th one? It'll come to me in a second. Vitamin D3, 5,000 international units a day. So, most of the multivitamins people take are just not getting them where they need to get. That will prevent vitamin malnutrition if you follow the government basic, minimum. But that's not optimal nutrition. And then, if they're able, we do want some physical use of the body, some kind of regimented use, whether it's walking or something more. Someone with a knee problem is going to have struggles anyway, so we need to find the right thing for them. So and then afterwards, I like peptides, like it's 5-amino-1Q, I think, is one of them. We use the BPC. I have a number of men in my age group or older that have never even known their testosterone levels. So we like to optimize the bioidentical hormone replacement first, because the body needs that. We look at thyroid, and then there are peptides also. We, instead of just throwing hormones at people, we not that that's a bad thing, but we also have bioregulator peptides, small peptides, which can help reset some of those gland activities that produce small molecules that tell our cells to behave more youthfully. So I look at everyone as an individual, and we take it from there. People also, some of these are injectables. People don't like to give themselves shots. Again, I have to gauge the appetite of the individual.
Yeah, when you're working in this field, it's so much more of kind of this like collaboration, because a lot of it does fall on, the patient is like, you have to show up. This is not the old school medicine where it's like, you go to the doctor, you get the shot, and you go home and you keep doing whatever you want to do. Like there's a much
Right.
more collaborative environment in regenerative medicine than, old school medicine kind of 2.0, if you will, to steal Peter Attia's terminology.
No, I agree. I think the people that seek out the biohacking and the anti-aging and the regenerative medicine are generally people who are willing to be involved. They are looking for something better than the current state of sick care in this country.
How important is a healthy inflammatory response after we use regenerative medicine, whether that's exosomes or stem cells or PRP? I've gotten conflicting recommendations from different doctors of um, how do we handle the inflammatory process after.
So this requires, I think, the answer a little deep dive into inflammation, because that word is broad. So if you'll allow, if you injure yourself, let's say you bump your arm hard somewhere and it's bruised, what have you, your body is going to attempt to heal that through a process called acute inflammation, where it sends the healing cells and the signal and the factors, and it does the healing, and then it should resolve within a number of days if you're young and healthy. And that should be it. You're done. Maybe a little scar tissue inside, but sometimes not. If that process doesn't turn off, it becomes chronic inflammation, and it sort of leaks and continues. And it's that process of chronic inflammation that causes degeneration, deterioration, and disease processes. If you look at most of the diseases of aging, they have a biological relationship to chronic inflammation. So to answer your question, the process of regenerative medicine takes advantage of acute inflammation and the small growth factors and protein and heat shock proteins and all these peptides that are in regenerative medicine, that overlap with some of the peptides we can take, shut off that process of chronic degeneration. So it does the healing and only the healing, and then turns it off like we were young again. And it's one of the reasons we don't want patients to take other anti-inflammatories after a regenerative procedure, before or after. We want them off any type of cortisone. We want them off, you know, like Advil, ibuprofen family, Aleve, naproxen family, all of them. In fact, interesting side note here. I helped a person with multiple lower extremity joint issues. She's in her 70s. And I was following her monthly. She's from the East Coast, so we were doing this by Zoom. And I was going over her medicines with her, and she says, yes, I'm taking this steroid inhaler for my asthma. And I had asked her to stop it a while ago, and for whatever reason, it escaped us. And her progress was a little bit slow with the joints. And I said, do you have asthma? She said, well, I had it 4 or 5 years ago when I had bronchitis, and my doctor just hasn't stopped it. So I said, well, check with your doctor, but I would stop it and use it only if you have to use it, right? If you got to breathe, that's important. So she stopped it, and in the third month of her recovery, her joint recovery accelerated, and she is, depending on the joint, between 50 and 85% better, and she can walk further, and she hasn't needed the steroid. So that steroid inhaler was holding back her knee regeneration.
After somebody has a stem cell procedure, I'll kind of fill you in where these questions are coming from. What we often will try and do is, can we keep chronic inflammation down? So it is common that they'll go through some cryotherapy after kind of an initial phase of like waiting, let's say 6 weeks after they've done it. They'll do Katsu, They'll do blood flow modification, retraining. We do quite a bit of infrared, like red light therapy, high intensity laser stuff, so that we're giving all those cells a bit more energy to process the stem cell or the exosome. And we're always trying to like walk that line of making sure that you're not creating a local inflammatory response, but you're keeping the kind of chronic inflammation down. What would you add to that? What would you add to our little protocol for the post stem cell stuff?
And I love what you're doing. I didn't mean to skirt over that when I said therapies. I mean, you're at the cutting edge of this, right? I would probably add flexibility training. We do know that pulling on the tendons at the bone, these attachments do stimulate stem cell activity. So you probably already do that, and it sounds so simple. Of course, we do strengthening and stretching. It's important. I do like hormesis in general, and I threw that word out. But anything that causes a slight stress on your tissues and cells that builds resilience is good. So, you talk about ice therapy, but people could do cold plunges. People can do the hot sauna, and some of the infrared lights can simulate that in a local environment, and they do stimulate stem cell activity. I would say I do like the blood flow restriction to build muscle. That again with protein and the right peptides. That's probably it. You can only do. I mean, otherwise you got someone in your therapy office, 3 hours every day.
Right. For you talked about this, and I'd like us to kind of spend a minute on it. In terms of looking at somebody retraining stuff, and we're going through some of that. Obviously, depending on the body part that you have, what we're trying to do is really identify what movement issues people have. When we talk about the spine for that, a lot of what you're looking at is kind of a 360 view of the muscles that stabilize the spine whenever we're moving. Can you give us a little bit of your thoughts on kind of core exercises and the core musculature that people should be paying attention to after some of this stuff?
Yes. So as long as we can define core as all of the muscular support elements 360 degrees around the spine, because you say core to some people and they say, oh, my abs, and all the abs are part of them. They're not all of them, right? So
not to cut you off, I hate the word core. I haven't figured out a great way to like substitute something else for it. But it's like the only one that is spread so far. You almost have to use the word to debunk what the original meaning was.
100% agree. Yeah.
Anyway, carry on. Sorry about that.
No, well, no problem. Listen, I think so first of all, let's talk about abs. I think that we need to work the transversus abdominis more than we do, and even more than the show muscles, more than the rectus muscles. And the way to do that, I'm sure you have many ways, but planks, there are vacuum, suck-in exercises that really activates and helps the lumbar spine, and it has other health benefits beyond that. I mean, I think we've missed the boat on it. We're all too busy doing crunches and whatever, So let's get back to the transversus abdominis. If you want a thinner looking waist, that'll help you get there faster than the rectus, training the rectus. Paraspinal training is probably, I'm speaking lumbar just for this purpose in general. These are the muscles in the back of the spine. We don't use them much in life, but we need them even more than we probably need the abs, because most of us have done ab calisthenics throughout our life, or we should have, but we probably haven't done back extensions with twists and planks and stuff. I think a great plank workout is ideal, and then you can do side planks and work the obliques. I also like, and we might add this as an answer to your earlier question about what other therapies might we include, is I'm a bigger and bigger fan of vibrating plate exercises, working the small stabilizer muscles. I don't know if you have that in your clinic, but you look at we have over 600 muscles in our body. A good third of them, and some are very small and just go segment to segment, are in the spine from the top down.
Yeah.
And they probably don't get a third of our love. And a lot of them are stabilizer muscles. And you will build your extremity muscles better and safer if you have a better axial set of muscles. That means up and down the spine, right? That part, it's called the axial skeleton, is up and down the flagpole of the body. So I think a lot of that can be done using the vibration plate and balance type things because they're stabilizers. If you got the stabilizers, it's easier to isolate for the big show muscles.
I'll tell people kind of, we really specialize in how do you stack different therapies together to get the most out of them. One of my favorite things is to do balance and stability training with blood flow modification bands on a vibration plate. You're getting like triple bang for your buck in that. And you're doing something that very few people do. I almost never see somebody who comes in doing stability work. I don't see nearly enough people who have kind of static core strength in their body. Those stabilizer muscles aren't firing well enough. And a lot of people aren't getting those muscles. They're not working them to the point where we're stimulating enough growth hormone. So if we just stack all those together, you got like a 15-minute program that you're like, I'm set. I'm checking a lot of boxes right now.
I would love for you to open an office here in the greater Las Vegas area. I'd sure share some clients with you, no problem.
Hey, look, you can not rule things out, right? So shifting gears a little bit, let's kind of talk about the longevity part of this stuff, because when I see stem cell for this, obviously this is in my wheelhouse and it makes sense. When we start to look at the longevity component of regenerative medicine, part of me is like, I really just don't quite understand what are the possibilities that we have on the horizon if we're leaning into that. What could this look like if we're doing regenerative medicine correctly for longevity?
Well, it has to have a little bit of every category. You've got to have the weight-bearing exercises and the muscle maintenance and the bone marrow maintenance and the diet and the protein and the mindfulness and the sleep. Sleep is a big component. If you talk to Brian Johnson, who spends lots of money on tech and stuff, supplements, sleep, and exercise are probably his top three with sleep. I mean, he's very big into sleep. And I saw a funny Instagram post. It's something about I've never been so healthy having moved in my own bedroom or something. We all so restorative sleep. Some people think they sleep well, but if you have any wearable tech like an Oura Ring or an Apple Watch, HR, you should track your HRV. And we have health metrics now that tell us a lot. Moderation of alcohol and other detrimental things, the right phytonutrients, fruits, vegetables, or some kind of supplement regimen that replaces what we just don't get in our regular foods, in our mass farmed foods, and in our diet. And even our meats, you think about free range meat a few hundred years ago is very different what those animals ate and how the fats are involved in those animals and what we get. So we really have to work towards that. Reduction of stress. Neurostress is inflammatory, and we want to do that as well. So it's the whole shebang. And assuming you've done all that, and you've optimized, you're interested, there are wonderful things you can do with regenerative medicine to help your cells program to stop chronic inflammation or slow it, and help you slow the onset and or help to work against disease processes. Aging is really an accumulation of chronic inflammation. And that's why you might see two 90-year-olds and they look very different depending on how hard someone's life is and their exposures versus someone else. You don't see that at the younger ages because the 90-year-olds have had more time for their curves to diverge, and you can see the difference. How they take care of their skin and staying out of the sun or using good sunscreen, for example, is how they look. But Think about their tissues on the inside. And there are great tests for this. We have biological age tests now. So you might be 85 on your birthday, but your biological age test might show you as 71. And we can use those to tweak things and get better. And the ultimate way to do that is to use usually intravenous exosomes, stem cells, things like that. And you don't need to leave the country to do it.
Take me through that process. Somebody like me. You're looking at people who are showing up. They're like, hey, look, I think I'm checking these boxes. They're in that 40 to 50 age range, and they're like, I just want to start as early as I can to start getting healthy. You start to do the kind of, let's do some tests to see where you're at on the inside. Talk us through what would the perfect scenario be?
Yeah, so I get on remotely with a Zoom. It's like a podcast with somebody, and we go through. I have an intake. We go through their supplements, their vitamins, their diet, their lifestyle. We start to make the tweaks to help them get where they need to get. We do like to do some blood tests, hormone panels, inflammatory markers, which most doctors don't do normally, and usually some type of biological age test that looks at either the glycosylation of antibodies, meaning the sugars attached to antibodies in the bloodstream, and or intracellular markers like telomere length and other DNA methylation. All of these correlate together and well with physiologic age, or what we call biological age, as opposed to your calendar age. So, and it gives us a baseline. So we start making these changes, and then we can repeat the test in 6 or 12 months and see what it looks like. And for those that are inclined, when we get everything optimized, if they want to come to see us or a clinic near them, that also offers, we either do, I'm a big fan of the exosomes. I've done them myself every few months, and it's just a 1-hour IV, and then we see what the results are. Usually it's how you feel. It's, we have people feel refreshed. They can recover from workouts faster. They sleep better. Our typical responses, clarity of thought, kind of clearing the cobwebs, helping cognition. And we also have addressed people recovering from heart attack and stroke and injuries and traumatic brain injury, for example. And this is separate from the joint work and spine work that we do. And they come to town for that. And then we have one guy, a very athletic guy, who said, "Yeah, I don't feel too much," but then he sent me a snapshot of his Oura Ring or Whoop Band. I can't remember what he had, and his HRV. I don't know if you track your HRV, Derrick, but his HRV was pretty good. It was running in the 60s, jumped to the 90s after an exosome IV for a number of months. So we know that these are doing some really great things for your cellular activity, your cellular health in general, and because of that, it works to slow your biological aging.
And then would that be something like, you come and get an exosome IV once a year, twice a year, something like that, and just keep on going?
Yeah, I don't have anyone on a working regimen like that except myself. I like to say, let's try one, see how you feel, see how long it lasts. I want people to feel great, and then at some point, months later, when it kind of wears off and that effect is left, they look and go, oh yeah, I want to feel like that again. They call, they call. So that in that time frame, if that's a 6-month or whatever, 3 months, depending on how old and how inflamed they are, great. Everyone's going to have their own individual, regimen. Plus, there's travel. If you don't live here in Las Vegas, you got to travel, and we're a decent destination like you are, so people will come here, and some people come routinely once or twice a year anyway because they meet their friends or what have you. So it just depends on the individual. But yeah, I mean, you find what's best for you. Once a year, twice a year. I'm doing it 4 times a year, but I started late.
Yeah, that's the question is you look at this. I had Joseph Antone on, who's with El Nutra, and they do a lot of research on fasting and longevity. And that's kind of what he said with that too, is if you start early, you maybe could do 1 a year, and you've accumulated enough that, you've cleared out cell stress, and I wonder if in these situations, if people are interested in kind of using this kind of health hacking, advanced regenerative medicine, the earlier you start, like the least amount you have to do in terms of intensity over a time span. That's quite interesting.
I would agree with you. It's the old area under the curve, right? It's how much and how often. And if you start earlier, you won't need to get the same effect. You probably will not need to do it as often if you start early.
Have you seen the we had a podcast on it. We had a bunch of patients asking me about it. The Blue Zone Live to 100 Netflix documentary.
I started it. I haven't finished it yet because my significant other, she doesn't like to watch documentaries. So she has to be busy doing something else for me to watch it.
You look at some of that stuff and look, these people are, you look at some of the people in that series and you're like, this guy's 100 jumping on and off of horses and running around and stuff. If we were to do this, do you think that if somebody does this consistently, I know this is kind of crazy, but what is the healthy kind of aging limit that we could hit? What's that top line that you could see somebody, if they started this early, they're checking all their boxes, they're keeping stress under control, they're coming to you, they're keeping all their cells healthy. What could aging look like?
Yeah, I mean, there's no reason that with clean living, like some of those people do in the Blue Zone, good eating, good exercise, good social environment, all the check all the boxes like you said. Add the regeneratives. I mean, there's no reason we couldn't have a healthy population into the 120s to 140s range.
I think some of this, you talked about it earlier, like the mindset stuff. There's people, and I know a few of them who hear that and they almost immediately get this like nervousness, or like their brain goes to like, we're so programmed to think that getting old means losing function. And with the work that you're doing, like, that doesn't have to be the case, people. Like, we can see somebody who is just having a blast and not hurting and doing everything they want to do through the aging process, if we're tapping into kind of science and research like this, on top of everything you said from the healthy living standpoint.
Yeah.
We can't separate these things out.
Yeah, the earlier you start, I mean, I'm looking at this, I'm getting into it in my 50s, and I wish I had started this many years earlier, of course. So for the younger people in the audience, don't put this off if you want to live long. But make sure you plan accordingly, because your 401k is going to run out when you're about 72.
Don't rely on 401k and Medicare, most likely. I know that a lot of this, when we start talking about people getting access to it, we want them to be able to get these things, and we get the question all the time. I'm sure you get it every day. It's like, well, why doesn't insurance pay for some of these things if there's such amazing benefits from it? Let's at least touch on that so that people have some answers to it if they're starting to get interested in these things.
Well, you got to follow the money. So, there are very, very big and profitable and powerful companies that make money off sick care. They want you sick. And since most of healthcare dollars are spent in the later years, they're trying to save money by fostering that sickness and sell pharmaceuticals and implants. And they are tied into the people who make those decisions in government. So make your own decision, though. Otherwise, you'll find me buried in the desert here. I don't know what you say in Louisiana, but here in Nevada, we find ourselves buried in the desert. So
we would probably have something swamp related. Don't go around anybody who has pigs or alligators. So, what would these procedures look like in terms of like, kind of cost and stuff like that for people?
Well, an IV here in the office, high dose exosome IV is think just under 4,000. And I don't think you'll find a price quite that good in the US. Um, we actually have gotten away from the cells. We've done them, but the exosomes are, in my mind, more efficient, both from a cost perspective and a biological perspective. A lot easier to handle. We're just not harvesting anyone's bone marrow. People do it in other clinics in the country. I think it's fine. I'm not. I don't want the old stuff put back in me. I want the young stuff.
Yeah, yeah.
So, cost. Joints. So joints we actually do at a local surgery center under sedation because we are injecting in the bone, like Dr. Hernegal from France. So that can be painful. So it's a 10 or 15-minute sedation. It's not general anesthesia, just enough so you can tell your friends you didn't feel anything. So I have to pay for the center and the anesthesiologist to do the sedation. But if it's usually let's say it's a meniscus, it's usually a dose above and below, and something like that I think it's under 10,000. I can't remember if it's 8,500 or 9,500. The extra, my big costs are the surgery center and the doses of the biologics.
Depending on kind of what's going on in those situations.
Yeah. And everyone's different. And, some people will use their health savings account plans if you have them. And that's where, you set aside a little bit of money at the front end of your insurance plan, to do it.
Doc, this has been a boatload of information. I've got notes like up and down my pages. When people are trying to find you, they're trying to find more out about Recelebrate, about what y'all do, about all the information that you put out there. How do they find some of that information? How can they hit you up for some questions after this?
Totally. I like to meet new people, and if you mention that, look us up. If you mention you found us on Derrick's podcast, we'll do a little. We'll waive the consultation fee, just to get you started. Just have a conversation. Just mention Derrick's name, and you'll get a good seat. So, but yeah, all our channels are called Recelebrate. So, because we're celebrating the rejuvenation of your cells. So RECELLEBRATE. We're also working on a kind of self-paced anti-aging how-to course. If you want more information on that, it's not quite ready, but if you want to get on the list, it's Young Again Method /longevity. YoungAgainMethod.com/longevity. Check that out. We have Instagram, TikTok, all the fun channels. You can look up Recelebrate and Young Again Method or Get Young Again.
Awesome. Doc, we ask all of our guests, if you could tell people listening to this one thing they could do today to get healthier, what would that be?
It would be exercise. That's the single most useful and probably easy thing, even though sometimes it takes motivation to get off the couch in the evening or whatever it is. Exercise is the most anti-inflammatory thing you can do.
That is a fantastic answer. I agree 100%. I think there is 95 days left in the year while we're recording this. When y'all hear this, there'll probably be, 60 days left in the year. So you have plenty of time left in 23 to get your exercise habit going and challenge yourself to close this out on a consistent note. Doesn't matter what you do, just be consistent with it.
Agreed.
Thank you so much for coming on. This has been brilliant. Everybody, you can always find more information. We're going to tag everything. We're going to put all y'all's contacts in the notes there. So y'all go find that, and we'll get you some easy links over to Dr. Jeffrey's clinic and all the information that we talked about today. Thanks a lot for coming on, Doc.
Thank you so very much.